Good evening, everyone, and welcome to our upcoming session on BK virus and how to detect it early. We have with us Dr. Ajay Kher. Dr. Kher did his MBBS from AIMS, his internal medicine from Indiana University, US, and he completed his nephrology and kidney fellowships from Beth Israel Deaconess Medical Center, Harvard University. He has won numerous awards and published multiple articles. He has given lectures on subjects like hypertension, diabetes, CKD, dialysis, kidney transplants, and complex electrolyte disorders. Over to him for a fruitful session on BK virus and how to detect it early.
For the introduction, I am Dr. Ajay Kher, and my talk today is going to be early signs of BK virus. What I'm going to go through is I'll talk a little bit about immunosuppression window, as it's very important to understand as it relates to BK virus, but also for transplant patients to know about in general. We'll talk a little bit about the BK virus itself, the early signs of BK virus, BK nephropathy, which is BK damage to the kidney, and then how do we manage patients with BK nephropathy. So to start, we'll talk about immunosuppression window. And so what I mean by this is that when we are trying to manage patients with transplant, there is this window which is the right amount of immunosuppression, which is your immunosuppressive medicines, which is tacrolimus, cyclosporin, mycophenolate, steroids, and there is an amount which is the just right amount for each individual. If we give too much medicine or too much of this medicine, the person is at risk for getting infections. If the amount is too little or too less, then the person is at risk for rejections. And this window, or the amount that this window is different for different individuals. So let's say this is for individual one. Another person, let's say someone has a second transplant or has had a rejection before, the window will be different for them. So for them, the window might look something like this. Again, there is the part where it is just right. And again, if you give too much, it is infections, too less, it is rejection. And because they're at higher risk for rejection, that window from where it is for someone else might be a much narrower window. In contrast, it could be a different window for someone who is at more risk for infections. Someone who's had tuberculosis or has had repeated urine infections, their window might be a different window. And what is important to understand is that there is no single test that tells us which is the person who's in which window and where they are on their journey in that window. So for the same person, at some point they might be in the window and some point they might be outside of that window. And so what is important to understand is that it is the clinical events. If someone has a rejection or someone has an infection, that does inform the patient as well as the doctor that they are outside of that window. And ultimately, it is the clinical judgment and the experience of the physician or the doctor that guides, and that's how we target and try and approach each individual patient, looking at their past history, their overall uh, transplant history, as well as their medical history, as well as their current transplant trajectory, to see whether we think they're in the window or whether they're outside of the window, and then make adjustment in those medicines. And BK virus is particularly an infection that is increased when the immunosuppression is high. And we'll talk a little bit about that next. So BK virus, so about 60 to 90% of adults would have had infection with this virus at some point in their life. So now we are talking about general adults. So all adults in the world at some point would have had an infection. The infection is usually an asymptomatic infection that they would have had in childhood. And then this virus kind of hides and has a lifelong persistence in the kidney, ureter, or bladder, or all of them. In healthy adults, so if we just start screening everyone on a routine basis, on a regular basis, 10 to 30% of healthy adults will have BK virus in their urine on some point or the other. And only in the setting of immunosuppression is there this reactivation that can then lead to kidney damage, especially in kidney transplant patients. So now let's look at how BK virus would present in kidney transplants. So there can be BK virus that is only in the urine, just as it can be in healthy adults. It can also be in transplant recipients. So 25 to 30% of kidney transplant patients will have BK virus in the urine. By itself, it doesn't mean that it is causing damage in the kidney. Then a smaller percentage of the patients or of the people who have BK virus in the urine will have BK virus in the blood. So in comparison to 25-30% who have it in the urine, 10 to 15% will have it in the blood. And a smaller fragment of this will have BK virus that will then damage the kidney, or BK nephropathy. And this is going to be somewhere in the 1 to 10% of transplants. So this is kind of the spectrum of the BK virus in the kidney. And what are kind of the features of it? Features are that usually this BK nephropathy, by the time it's going to damage the kidney, is usually going to be the 2 to 6 months of transplant. And even if it is beyond, it will usually be within the first year. And the usual reason is that at that time, within the first year, we are using higher immunosuppression, or your medicines are higher, or you may have had an injection at the time of transplant. And so the transplant medicines or the immunosuppression is higher. And so that is the time when the virus will also be likely to act and multiply and then damage the kidney. Another feature could be that if someone has had a rejection, let's say at 1 year or 2 years or 3 years after transplant, in those settings also we increase immunosuppression, and a few months after that also BK virus can activate and start causing damage. Another feature to know about is that it can lead to persistent damage even after the infection has been cured or the infection resolves. The diagnosis of BK nephropathy is only possible on kidney biopsy. The blood and urine testing is helpful, but it will not confirm that that is causing damage in the kidney. So another things in terms of the signs, which is the talk, unfortunately, there are no symptoms from BK virus. So even though the talk is called early signs of BK virus, unfortunately, there are no symptoms or signs that you would feel or you would be able to tell that, okay, this is coming from BK virus. Occasionally or usually, people with BK virus may have pus cells or WBCs in the urine, but that can happen from infections. It can happen from allergies to some medicine. So there are lots of other reasons why someone could have pus cells or WBCs in the urine also. And that doesn't by itself mean that it is from BK. So how do we suspect or how do we diagnose BK nephropathy? We have to have a high index of suspicion. So anyone with increase in creatinine, especially if it is within the first year, we have to think about BK nephropathy. We can do blood testing for BK virus. So again, that would raise our suspicion that the BK is possibly causing damage. But again, to be 100% sure that that is what is the cause, we have to do a kidney biopsy. So transplant kidney biopsy would be required. And again, many times the biopsy itself may look similar to rejection. So treatment for rejection is, if you remember the window, we have to increase the transplant medicines or immunosuppressive medicines. The treatment for BK is to lower the medicines. So they are actually completely opposite treatment modalities that we have to do. So which is why it is very important that when we do a transplant kidney biopsy, that we do the special BK staining to confirm that what we are seeing is rejection or what we are seeing is BK nephropathy, because the treatment modalities will be completely opposite. So what would be the treatment if we diagnose someone with BK nephropathy? The treatment is we have to cut down on the medicines, the transplant medicines, the immunosuppressive medicines. So whether it is tacrolimus, cyclosporin, mycophenolate, azathioprine, steroids, the overall amount we would have to cut. Which one to cut, how to cut, there is no consensus on the best method, and hence the exact specifics of which medicine and how much to cut would be based on the individual's track history, as well as transplant history, as well as what we think is the risk of rejection when we cut down the immunosuppression. And no matter what we do, we would need to continue to closely monitor as we reduce the immunosuppression to see what is the response from the BK standpoint, and to make sure that we don't develop a rejection as we are reducing this immunosuppression. So that would be in terms of treatment. So to conclude, in terms of prevention, the two things that we can consider doing would be: one, avoiding high immunosuppression and trying to hit the window. So again, it is easier said than done. Unfortunately, as we discussed, there are no tests that we can do that would tell us that this is the exact amount, that is the right amount for an individual person. So it is based on judgment of the physician and the history of the patient. And then something that can also be considered is to screen routinely, which would be to do monthly blood BK PCR for the first year or for the first few months. This is something that is done in some transplant centers in the West, but is not routinely done in India, and predominantly that is due to cost. So if that is something that we suspect that this person is at a high risk, or a person is keen on looking and evaluating for BK, that is something that can be considered on a case-by-case or an individual basis, and would reduce the risk for BK in the future. So to conclude, BK virus is present in almost all adults. BK nephropathy is asymptomatic. So unfortunately, there are no easy signs or symptoms that would identify who is going to get BK virus infections or BK nephropathy. And so we have to have a high index of suspicion to suspect and then diagnose. And for diagnosis, we would need a transplant biopsy and need to do a BK virus staining on it. If BK nephropathy is diagnosed, lowering immunosuppression is the treatment that we would have to do, with close monitoring in the future.